All right, let's jump straight into this explainer. This is the Clinical Gauntlet, high-yield pharmacology and toxicology. We're going rapid fire through scenarios where one single clue completely flips the management plan. Let's hit case 1.
Section 1, Toxicology and Overdose Resuscitation. Let's go.
Okay, here's the stem. Your patient rolls in with altered mental status and a distinctly dry mouth post-ingestion. You check the ECG and boom, a prolonged QRS complex. What's your best next step? It's intravenous sodium bicarbonate. The absolute clincher here, that QRS widening. Now, I know you might be tempted to jump at physostigmine, but hold on. Physostigmine is strictly for pure antimuscarinic toxicity without QRS widening. If that QRS is wide, it is sodium bicarb all day to overcome the sodium channel blockade.
Next up, a patient ingested 10 grams of acetaminophen exactly 3 hours ago. Vitals? Completely stable. So, what's the best next step? It's activated charcoal. The defining factor is your timeline. It's been less than 4 hours since the ingestion. Giving N-acetylcysteine right away is a classic trap here. You only use NAC if those acetaminophen levels actually come back above the treatment line on the nomogram, or if the timing of ingestion is completely unclear or greater than 4 hours.
Moving on, a house fire victim is brought in. They've got cherry red skin, an elevated lactic acid level, and altered mental status. What is the antidote? You want hydroxycobalamin. The major clue? Smoke inhalation presenting with an anion gap metabolic acidosis. Now the trap here is reaching for sodium nitrite plus sodium thiosulfate. Don't do it. Nitrites induce metamoglobinemia, which is strictly contraindicated. Why? Because structure fire victims already have concomitant carbon monoxide poisoning. You absolutely cannot compromise their oxygen carrying capacity any further.
Case 4. A patient presents after an oil of wintergreen ingestion. They're hyperventilating, pH is 7.2, and they have new onset pulmonary edema. Best next step. It's hemodialysis. The crucial point here is the pulmonary edema. That marks the patient's absolute inability to tolerate large fluid volumes. The trap is intravenous sodium bicarbonate. Look, bicarb works beautifully to alkalinize the urine, but only if the patient can tolerate the massive volume resuscitation required without going into total respiratory failure.
All right, next stem. A patient is in severe bradycardia and hypotension, accompanied by hypoglycemia. They are completely refractory to IV fluids and atropine. Best next step? You need glucagon. The hypoglycemia combined with refractory bradycardia points directly to beta blocker toxicity. A super common misstep is just giving calcium gluconate alone. Calcium can definitely help the blood pressure, for sure, but glucagon is the specific antidote you need to bypass that blocked beta receptor and directly crank up intracellular CAMP. Here's case 6. A farmer presents with copious diarrhea, urination, pinpoint meiosis, and muscle fasciculations. What's the best initial step? Atropine. Those muscarinic airway symptoms and secretions, they must be reversed first to literally save the patient's life. The trap is giving pralidoxime first. Pralidoxime is absolutely administered, yes, but strictly after atropine, and that's to reverse the nicotinic muscle weakness and fasciculations. Section 2. Critical ECGs and electrolyte emergencies. Let's keep this momentum going. Case 7. An end-stage renal disease patient on an ACE inhibitor presents with severe weakness. You look at the ECG and see a classic sine wave pattern. Best next step? Give a calcium gluconate infusion. That sine wave ECG screams for immediate cardiac membrane stabilization. The trap is reaching for insulin, with glucose first. Insulin is definitely given rapidly to shift potassium, but strictly after calcium secures the myocardium from fatal arrhythmias. Next stem. A patient on haloperidol and a macrolide antibiotic presents with palpitations. The ECG shows polymorphic ventricular tachycardia with a cyclical variation in morphology. Best next step? It's magnesium. What we're looking at is torsades de points triggered by a combo of QT prolonging medications. The trap is giving standard amiodarone. While amiodarone is used for standard wide complex VTAC, it would be an absolute disaster here because it further prolongs the QT interval, making the torsades even worse. Section 3. Hyperthermia and rigidity syndromes. Case 9. A patient on citalopram and tramadol develops acute agitation, diaphoresis, hyperreflexia, and clonus, all within just a few hours. Diagnosis? This is serotonin syndrome. The defining features here are the hyperreflexia, the clonus, and that rapid acute onset. The TRAP diagnosis is neuroleptic malignant syndrome, or NMS, but remember, NMS presents much slower, over days, and its absolute hallmark is lead pipe rigidity, not hyperreflexia or clonus. Moving to case 10. A patient given promethazine for nausea develops a high fever, lead pipe rigidity, and severe autonomic instability over 3 days. Best medication step? You need to stop the offending agent and give bromocriptine or dantrolene. The determining factor is the dopamine blockade, causing that slow-onset lead pipe rigidity. The trap is cyperheptadine. Cyperheptadine is the specific serotonin antagonist antidote reserved exclusively for serotonin syndrome, not NMS. Case 11. An intraoperative patient receiving volatile anesthetics develops hypercarbia that is completely resistant to increased ventilation, plus massive muscle rigidity and rhabdomyolysis. Treatment? Immediate cessation of the anesthetic and intravenous dantrolene. The big distinction here is the resistant hypercarbia triggering specifically during anesthesia exposure. The trap is bromocriptine. Sure, bromocriptine works for central dopamine blockade in NMS, but it does absolutely nothing for the peripheral massive calcium release from the sarcoplasmic reticulum that we see in malignant hyperthermia.
Section 4. Anticoagulation and skin crises.
Here's case 12. It's day 6 of IV heparin therapy, and the patient's platelet count suddenly drops more than 50% from baseline. Best next step? Stop all heparin products immediately and start a direct thrombin inhibitor like argatroban. The clue is that classic 5 to 10 day timeline combined with that massive drop indicating heparin-induced thrombocytopenia, or HIT. The trap is to just continue heparin and order a serotonin release assay. The SRA is indeed the gold standard confirmatory test, sure, but this is a clinical diagnosis first. You must start alternate anticoagulation prior to confirmation to prevent fatal thrombosis. Case 13. So, 14 days after starting allopurinol, a patient gets flu-like symptoms followed by rapid mucosal necrosis and epidermal sloughing on 20% of their body surface area. Diagnosis? This is SJS/10 overlap syndrome. The timeline of mucosal involvement happening 4 to 28 days post-trigger, spanning 10 to 30% of the body, differentiates this right away. The trap here is staphylococcal scalded skin syndrome. But remember, SSS generally affects children via an exotoxin, and crucially, it completely spares the mucous membranes. Moving on. A patient on warfarin presents with massive, severe gastrointestinal hemorrhage and an INR of 6.0. Best next step? The answer is prothrombin complex concentrate, or PCC, and vitamin K. Life-threatening bleeding demands immediate factor replacement. The trap is simply holding the warfarin and resuming when therapeutic. Holding the dose is only appropriate if there is 0 to minimal bleeding. Massive hemorrhage means immediate reversal, no exceptions.
Section 5. Obstetric emergencies and contraindications.
Case 15. A patient has a postpartum hemorrhage. She also has a known, documented history of severe asthma. Which uterotonic medication is strictly contraindicated here? The answer is carboprost-tromethamine. Carboprost is a prostaglandin F2 alpha analog, and it triggers intense bronchospasm. The trap is methylargonavine. Methylargonavine is a very effective drug, but it's contraindicated if the patient has hypertension, not asthma.
Case 16. A preeclamptic patient with generalized vasospasm and a history of myasthenia gravis requires seizure prophylaxis. Best medication? You want valproic acid. The key contextual clue here is that myasthenia gravis diagnosis. The trap is magnesium sulfate. Look, I know magnesium is the absolute gold standard first line for preeclampsia, but it is strictly contraindicated here because it blocks acetylcholine release. Giving it will trigger a fatal myasthenic crisis.
All right, case 17. A hemodynamically stable patient presents with an ectopic pregnancy, but she has underlying diabetic nephropathy. Best management? The answer is surgery. Why? Her renal disease prevents adequate drug clearance. The trap is methotrexate. Methotrexate is perfect for stable ectopic pregnancies, but only if renal and hepatic function are completely 100% normal. Otherwise, the toxicity risk is just way too high. Case 18. A pregnant patient has elevated AFP, and the ultrasound confirms an encephaly. What timing of medication could have prevented this? The answer is folic acid supplementation starting 4 weeks prior to pregnancy. The neural tube closes incredibly early in gestation. The trap is starting folic acid at the standard week 8 prenatal visit. Week 8 is entirely too late. The defect has already occurred.
It must be started pre-conception. Let's lock all this in with a 60-second clinical safety checklist. Rule 1. ECG danger always comes first. If you see a sine wave, secure that myocardium with calcium before you even think about fixing the lab value. Rule 2. Always check pregnancy status before handing out teratogens. And remember that pre-existing conditions like asthma, hypertension, or myasthenia completely dictate your obstetric drug choices. Rule 3. Verify renal and hepatic function before dosing anything, especially methotrexate or lithium. Rule 4. Stop the offending drug immediately at the very first sign of severe immune or toxic reactions like NMS or SJS. And Rule 5. Only use the antidote when the specific mechanism fits the exact clinical picture. Supportive care is critical, absolutely, but it is never enough when a reversal agent or decontamination step is time-sensitive. Remember, when the drug is the poison, stopping it is your only cure.